It's a great pleasure to introduce the next speaker, who will complete this session, Dr. Nafea Alyasi, who is one of our homegrown boys who's soon to be a mudir. You may all recall that he's done a lot of work on foreign body ingestion in the UAE and brought a lot of attention and awareness in this area. If you don't find him globe-trotting around the world or writing books on social media, he's a pediatric gastroenterologist as well at times. Today, we've given him a challenge of talking about Alagille syndrome. Nafea, the floor is yours. He's also promised to stick to his time limit, I believe.
No? Is it working? Can you hear me? Thank you very much, Dr. David. I think you mentioned social media in the middle. I don't know why. Anyways, my name is Nafea Alyasi. I'm a pediatric gastroenterologist. Thank you for having me here. Today, I'm going to talk about Alagille syndrome, which is a rare syndrome, but yet very common in the exams. If you are a medical student or if you're a pediatric resident, definitely you'll have a question about this. And this is Dr. Daniel Alagille, who discovered, or he identified the first few patients in France back in 1979. Is this working? Next slide. I have nothing to disclose today. Next. So Alagille syndrome, it is an inherited autosomal recessive, autosomal dominant disease affecting multiple organ systems, basically the liver, kidneys, eyes, heart, skeletal system, and major blood vessels. The incidence is between 1 in 40,000 to up to 1 to 70,000 patients. Next. As I said, it is an autosomal dominant disease. Some of the cases can be sporadic. The first mutation was identified. It was the JAG1 mutation, which is in chromosome 20p. This was identified back in 1997. The majority of the patients with Alagille syndrome, they will have the JAG1 mutation, more than 85%. The other mutation was detected back in 2005, the Notch2 mutation, which is in chromosome 1p. This was identified, as I said, in 2005. The minority of the patients, between 5 to 7% of the patients, they will have the Notch2 mutation. Next. So until now, there are unidentified mutations. There are variants of unknown significance. So if you have a patient who suspected Alagille syndrome and you send him for genetic mutation and it comes back with variant of unknown significance, this is expected. You will see it in around 10 to 11% of the patients. Next slide. There's no correlation between the phenotype and the genotype. So you might have two siblings with the same mutation, but the presentation of the disease is different. One of them might have mild symptoms, the other one will have severe symptoms. There is a possibility of the genetic modifiers, and this is under investigation. Next. So as I said, the clinical presentation, basically they will come to you as a hepatologist or a gastroenterologist. You will see them in your clinic. So you'll see basically liver disease, you will see cholestasis, you might see facial features, you might listen to the heart and you might hear a murmur. In the eyes, you will see some findings, kidneys, skeletal, and the neurovascular. I will go one by one to each one of them. Next. Starting with the liver, you will have the classic bile duct paucity. This is very classic in the majority of the patients with Alagille syndrome. Keep in mind that if you do a biopsy before the age of 6 months, you might have a chance of missing the bile duct paucity. Between 40 to 50%, they might have the findings before the age of 6 months. The majority of them, they will have it after the age of 6 months. Next. The distinct facial features, they are very common. You will see a prominent forehead. You will see a triangular face. You might see a pointed chins. This is more common in JAG1 mutation patients. And you see it less likely in patients with Notch2 mutation. Next. For the heart, mainly structural deformities. You'll hear, they will have pulmonary stenosis. Some of the patients may present with tetralogy of Fallot, and these are the complicated patients usually. They might have other features such as ASD, VSD, or aortic stenosis. Majority of patients with JAG1 mutation will have it. About 60% of Notch 2 patients will have cardiac defects as well. Next. For the skeletal anomalies, this is a typical exam question. They will ask you about the skeletal anomalies. They will have butterfly vertebra, and this is in the thoracic vertebra. This is much more common in JAG1 mutation. This is rare finding in Notch 2 patients. Next. As for the ocular, this is a very common finding that you'll see it. It is called posterior embryotoxin. This is the fine, thin white line in the edges of the cornea. This is a bilateral finding, can be easily detected by slit lamp examination. And this is also common both in JAG1 and Notch 2 mutations. Next. For the renal anomalies, you might have hyperechoic kidneys, you might have renal cysts. Patients might present with acidosis, basically renal tubular acidosis, and this is found around 40% of the patients with JAG1 and Notch 2 mutations. Next. For the neurovascular events, patients might present with intracranial aneurysm leading to strokes or carotid artery aneurysms, renal artery anomalies. This is rare finding in pediatrics. In general, this is rare, but this is more common seen in throughout the adulthood. Patients with Alagille, when they reach the adulthood, they might have those findings. These criteria, the ones I mentioned, are the major criteria for the diagnosis of Alagille syndrome. You might not have them all accumulated in one patient. You might have bits and bits of them. So the question is, how would you diagnose Alagille syndrome? Next. Oh, I forgot to mention these. Other features, you might have pruritus. Pruritus is a very bad symptom because the patients will have itchiness all the time due to cholestasis, and this is very annoying for the patient. This might affect their quality of life, even the parents' quality of life, because the patient is itching all day and all night and not being able to sleep. Keep in mind that pruritus itself might be or can be a reason for liver transplant in some of the patients. They will have developmental delay and poor growth, which is expected if they have multisystemic disorders. Xanthoma due to increased cholesterol, and you can see an image here of xanthoma and the extensive surfaces. And of course, patients with cholestasis, typically they might develop fat-soluble vitamin deficiency, so they might present with fractures or bleeding. Next. So for the diagnostic criteria, there are more than one criteria. This is the revised criteria. In terms of diagnosing patient with Alagille syndrome, you need to have 4 or more major criteria, the ones I mentioned. So most probably you'll have patients with liver. You might have heart, skeletal, and eyes. If you have 4 of these, this is diagnostic of Alagille syndrome. Or if you have a presence of JAG1 mutation plus one major criteria, this is itself is diagnostic. Or if you have a positive family history and JAG1 mutation, this is diagnostic for Alagille syndrome. You can see that the biopsy itself is not diagnostic. And I said in the first 6 months, the biopsy might be misleading. So if you are planning to do a biopsy and you highly suspect Alagille syndrome, I suggest you do it after the age of 6 months if you need it. Next. So what is the clinical course and the progression of a patient with Alagille syndrome? Well, if they have cholestasis, the majority of them, they will have cholestasis. They might progress to portal hypertension. Some of them, they might improve, but the majority, they will progress to portal hypertension or liver failure. They will have intractable pruritus, especially after the age of 6 months. And whatever treatment you might use, some of them, they might improve, but the majority, they might not improve. They will present and they will have malnutrition. They will have risk of fractures because of fat-soluble vitamins deficiency and bleeding as well. And of course, this will affect the quality of life of the patient and the family as well. Next. So what is our aim of the management here? Of course, the first aim is to reduce the cholestasis by using also deoxycholic acid. You can give them ADEC as well. Minimize pruritus by giving them antihistamines or rifampicin. And we all know that the improvement is not that significant on antihistamines or rifampin. Nutritional support, MCT formulas, fat-soluble vitamins, and the end point is by liver transplantation. And keep in mind, liver transplant is not a cure. Basically, it's substituting a disease with another problem. with post-transplant issues, with the immunosuppression. Next. So what is their transplant-free survival of the patients? Nearly 26% of the patients, they will survive without requirement of the transplant at the age of 18 years. The majority of the patients with Alagille syndrome by the age of 18, they will require a liver transplant at some point. Next. So as we know, the treatment so far is not that much effective. There is a new hope in a new treatment called the IBAT inhibitors, intestinal bile acid transport. You know that the bile acid is absorbed through the duodenum, going to the ileum, and through the enterohepatic circulation, goes back through the IBAT transport, goes back to the liver. So this causes increase in bile acids. So the aim of the bile IBAT inhibitors is to block the transport, the enterohepatic circulation, and causes excretion of the bile acids throughout the feces. So the first treatment, which was studied recently, is called Marixabat. Next slide, please. And this is the iconic study. This was a randomized phase 2 study. Next slide. So what they did is basically they recruited the patients. Initially, it was an open label study at the beginning. They gave all the patients Marixabat for 18 weeks, and they monitored the pruritus and the bile acids, serum bile acids. And from the week between week 19 and week 22, for about a month, they distributed the patients they randomized the patients. One group received Marixabat, and the other one received placebo. And they kept monitoring the pruritus and the serum bile acids. Then back again, they reintroduced the Marixabat to all patients, and they monitored the patients. So for the criteria for the eligibility for those patients, they were the patients from the age of 1 to 18 years old who did not have any transplant or any surgery, with chronic cholestasis and intractable pruritus. Next. And you can see here on the outcome. So all the patients who received, all the patients at the beginning, they received the Marixabat. You see the pruritus went down significantly until 18 weeks. The red line, they withdrew that and they gave them placebo instead. And significantly, the pruritus went up. When they reintroduced the Marixabat, the pruritus went down and significantly kept on the lower side. Next slide. Same thing for the bile acids. Once they gave them placebo, the serum bile acids went up. Reintroduced Marixabat, serum bile acids went down. So the two endpoints, serum bile acids and pruritus, are significantly decreased in patients who were receiving Marixabat. Next. And this drug was recently approved in September 2021 in the United States. Still, this is not available here in the country. I think in the next couple of months, this treatment will be available. This is a novel treatment, and next. It has pros and cons. Okay, for the pros, it's an oral dose, minimal side effects, mainly gastrointestinal symptoms, diarrhea, and mild abdominal pain. And this significantly improves the quality of life. We still don't know, does it really delay the progression of need of transplant? This will be evident more in the future. The cons of that, it is still approved only for patients the age of 1 year and above, still not approved for patients who are less than 1 year. The cost, it's very high. It's $391,000, so that's around $1.5 million per year. And this will be a difficult thing for patients who don't have insurance or from underprivileged countries. And we don't have any evidence, or we don't know the effect of this treatment on our local population. Probably by next year or by next couple of years, we will have our own data if we collect all our patients and start them on this treatment. Next. So the take-home message for my presentation today: genetic screening can be negative in Alagille syndrome. So if you have a patient with all typical presentation of Alagille syndrome, you might have a negative genetic screening. Okay, the severity is not dependent of the mutation. So as I said, you might have family members with the same disease, but they have different presentation. The majority, more than around 75% of the patients, they will end up having liver transplant. Hopefully in the future, with the availability of the treatment, marixabat, maybe we will have a delayed or lesser patients requiring liver transplant. And as I said, the IBAT inhibitors are promising treatment options that we will see the effect of them in the near future, inshallah. Thank you very much.